only mode.
Good afternoon and welcome to our CFN webinar series. Today we have development and testing of a standardized communication form to improve transitions for nursing home residents. Just so that you know, webinar and slides will be posted on our website. I have a few things just to review before we start the presentation. We are up for renewal, CFN, and we are preparing our proposal, and we're actively looking for partners to support our highly qualified personnel. We're looking both for partnerships in our interdisciplinary fellowship program and our summer student program. We sent out emails to most of our supervisors who currently have students, as any investigators in our network, as well as member institutions, likely your research services office, and we've extended the deadline to June 6th. So please let us know if you're interested. Either contact myself, Carol Berry, or Jackie St. Pierre, and we will work out what it is that you need or are looking for this initiative. We also have a video contest ongoing right now, and it will be closing on Tuesday, May 31st, and we're looking for videos on what frailty means to you. Another reminder, annual progress reports for research and interdisciplinary fellows, and Form 300s were due May 1st, and we still have a few outstanding and hoping that they can be submitted by end of day today, because we need these statistics on HQPs and publications, etc., for our NCE reporting, which is due on Monday. During this process in the webinar, if you would please submit your questions either using the chat function or the question. Either one of them are we will be able to read, and we'll try to answer as many questions as the time permits while trying to end at 1, and the questions will be at the end of the presentation. And again, the webinar is recorded and available probably in 1 or 2 days, and there's the website link right there. So without further ado, I will let you know a little bit about our presenter today. It is Greta Cummings. She's a Centennial Professor in the Faculty of Nursing at the University of Alberta. She leads the CLEAR Outcomes Research Program, and within it, the Older Persons Transitions in Care, OPTIC. This research program examines the quality of transitions of frail elderly clients across 3 settings of care. So continuing care, emergency medical services, and emergency departments. Dr. Cummings has published over 160 papers and is the 2014 highly cited researcher in social sciences. Dr. Cummings has received the Canadian Nurse Association Order of Merit for Research, and in 2015, something went on my screen, was inaugurated into the Sigma Theta Chi International Nurse Researcher Hall of Fame. So I pass this along to you, Greta, to start your presentation.
Thank you very much. Hopefully you can hear me and you can see my screen. I'm really pleased to discuss the OPTIC impact study on behalf of our research team. OPTIC impact stands for Improving Communication During Aged Care Transitions, and it's a study that is a follow-up to our original OPTIC study, and we have several OPTIC studies that are underway, all looking at different aspects of transitions. I'd like to acknowledge our research team. We have a research team from both Alberta and BC who are all a subgroup of the original OPTIC study, with the addition of Anne Giavetti from Alberta Health Services, who is in charge of the form that I'm going to be discussing today. I'd also like to acknowledge Sarah Cooper, who's our HQP on this study. She is now completing her master's, and she is doing a systematic review of the literature on all of the data elements that are shown to be important in these checklist kinds of forms that I'll be discussing today. And she is just about complete that work and has been a significant help on this study. I'd also certainly like to acknowledge the funding from the Canadian Frailty Network and the support of Alberta Health Services and the University of Alberta. This grant is a partnership with Alberta Health Services, and I'll go into that a little bit more shortly. So just to give you some background, the OPTIC program, which is the Older Persons Transitions in Care Research Program, is a larger study that's been underway for the last 5 years and which has spawned off several of these smaller pilot studies arising from the results of OPTIC. But our mission in OPTIC is to improve care of long-term care residents across the healthcare continuum. And so speaking to all of those transfers that, that take place during a series of transitions, and to identify those transitions that can be avoided, and to improve the transitions that are necessary. So all of our studies are working towards that. So the original OPTIC study was conducted in Edmonton and in Kelowna, British Columbia. The original data collection ran from 2011 to 2012, where we followed 687 seniors from nursing homes through their transition to the emergency department, to inpatients and back. This study included 38 long-term care facilities in total. We had 2 emergency departments and we had 1 emergency medical services department. And there was a excellent partnership developed between all of these different settings and the personnel who work in these different settings, because they all see improving transitions and avoiding unnecessary ones as a very high priority. So in our OPTIC 1 results, some things that we showed were some very significant gaps in documentation, in communication, in the availability of information about the resident to all of those healthcare providers during the transition of care. So the EMS providers, the emergency department physicians and nurses, consultants, etc. And so those significant gaps are what led to our team saying we have to test a form of either a checklist or an actual form that's part of the patient's medical record, and that's what led to this particular study. One of the key findings that we had both in our original OPTIC pilot as well as in the full study was very, very poor documentation of all of the assistive devices that residents require to interact with their environment, to have some quality of life and some quality of moment, even for those who have severe dementia. And what we found is that in both provinces across all of the 38 nursing homes, less than 5% of the time were glasses, dentures, hearing aids, walkers, etc. documented as either being with the resident or not having accompanied the resident. And so no one knows if they got lost along the way or they didn't actually ever go. This is just one example of many, many, many documentation gaps that we identified. We also have been working on a matrix of indicators, quality indicators for transitions in care. And this is just one sample of the outcome indicators that we have identified, process and outcome indicators that we've identified for the domain of safety in transitions. And you'll see here that handover communications and having access to appropriate information and documentation is a key quality indicator for transitions, and of course that in each setting complete medication reconciliation would be conducted and reported. So the impact study purpose was to test a standardized 2-page evidence-informed transfer form that would hopefully improve communications across these transition settings. And while we were working on our analyses of our OPTIC study, AHS was also in the process of developing a standardized transfer form because, as you can imagine, in a large province like Alberta with one health authority, there were multiple transfer forms that had been developed over the years and had never actually been tested. And so AHS was interested in standardizing these forms across any interfacility transfer. And so when we connected about the gaps that OPTIC had identified, we were able to contribute to the development of the form in terms of identifying some of the key data elements that should be on the form, arising from our study and from a few other studies as well. And so that led to this partnership between AHS and the Clear Outcomes research program to test this form. So the objectives that we had for impact were to pilot test this form in the same nursing homes in Alberta that we had in OPTIC so that we could compare to our previous OPTIC data. And we really want to pilot test the form so that it could be adapted after the pilot before it became a province-wide mandated form. That didn't completely happen because Alberta Health Services did want to send out the form for use partway through the work that we were testing, but we were still able to inform the implementation. And then we want to also assess the healthcare provider's assessment of the use of this form. Like, did they find it useful? Did they find that it was easier to find information about the resident than before they had this form, or with in comparison to any other form, which would be their standard practice? And then, of course, to assess rates of form completion and data element completion, so specific data elements within the form. So today, for the learning objectives of this webinar, I'm just going to review these three specific items. The fact that IMPACT is a joint partnership project between CLEAR and Alberta Health Services intended to improve communications, and also to discuss the impact of healthcare staff turnover. There's considerable turnover in the long-term care settings that had an impact on this research, as well as when we first started our long-term care research many years ago, there were very few researchers that were in long-term care, and now we're pretty much tripping over each other in the long-term care settings, and so research fatigue is certainly set in. And then another objective to discuss today is the when an organization, a healthcare organization, implements projects across multiple sites, settings, and providers, there's usually one site or one setting that has the burden of the work that might benefit another setting, and that's certainly what we saw here. So the impact transition process is, you'll see on this screen, beginning with a long-term care facility. So the resident lives in the long-term care facility and then is transferred by EMS to the ED, may be admitted or not, and then is transferred back either by EMS or by interfacility transport. And so this one standardized interfacility form would follow the resident all the way through this process. And it was a two-page form on NCR paper, so there were some issues around the copies either being legible, etc. But this was the initial pilot of that form. So on this next slide, you'll see this is a copy of page 1 and page 2 of the form. There's a great deal of detail in this form, but again, that was intended to cover off all of the information that would be required about a resident in a nursing home. And there were multiple individuals and representatives of various departments who had input into this form, both through AHS and through our research staff. So the flow of the document and how it would work is that in long-term care, the long-term care nurse would complete the green section of the form, which was all of page 1 and almost half of page 2, to provide the detail about the resident. and then they would keep the NCR copy, the canary-colored copy, and then they would provide this original as part of the chart to the EMS crew that came to pick up the resident during that communication handover. And we used a process similar to this as for training within long-term care and with EMS and ED as well. We had a whole training package. Then the EMS crew would complete the brown section of questions, which would describe in brief, in addition to their PCR form, that they had their interactions with the resident and information about the resident. And again, the same original form would then go with the resident to the emergency department. In the emergency department, the ED nurse would complete the receiving facility section, which is the first red section after EMS. And then when they were completing their care and they were ready to transfer the resident back or send them to inpatients, then they would complete the second red section, which would briefly describe their interactions with the resident, care provided, the status of the resident, etc. And then finally, the interfacility transport or the EMS crew who were returning the resident back to the long-term care facility would complete the final section, the final brown section of the two-page form. So the sample that we use and our same emergency department in Alberta Health Services was enrolled and participated, and also participated. So we did start off with training. We had a purposeful training of the nurses in the long-term care sites, the nurses in emergency departments, and the EMS crews. At the beginning of the study to the form, how the form would be processed, how it would be completed, how it would be useful, etc. We did most of this training through at change of shift time, or when they had what they call huddles in the emergency department, when the nurses would have a few minutes to communicate important information. And we did this repeatedly for several weeks at the beginning of the study to catch as many staff as possible. The EMS staff was a little bit different, so we had to actually send all of our training materials to the EMS managers, and then they committed to doing the training with the EMS staff. We had study research assistants who collected the forms from the emergency department once the patient was transferred in. And then they would make a copy of the form so that we could do our data collection off of the copy and our analysis. And so the original would always stay with the resident. And then we also conducted pre and post surveys with the staff in all of these settings to get their perspectives on how much information they get about the resident before this form was implemented and then after, and as well how quickly they could find information and how clearly they could find information. This was all done with 13 questions on a survey that, that we developed for this. So during the implementation stage of the study, we did identify a number of challenges. As I mentioned earlier, many of the sites identified research fatigue because they were involved in so many studies by so many different researchers. And in fact, they were having trouble keeping all of the studies clear in their own minds so that they could actually participate or not. And a few sites just said that they'd had too many recently so that they couldn't participate. We also found that high turnover of staff in long-term care meant that many new staff were being hired regularly and were responsible for the form and yet had never received training because we didn't go back during the implementation to do more training. We had left it to the site to train new staff who were coming in. And the research assistants also frequently encountered staff in participating sites who said that they were not aware of the study despite having this training, and that might be another indicator of the research fatigue. And the site staff frequently resisted using the new form, and in some of the sites they had actually already developed an electronic transfer form in private facilities. And so what we did in working with a couple of those sites, because we did want them to participate, and so did Alberta Health Services, is that if they completed their electronic transfer form and then printed it and attached it to our form, then we could use that as part of our study in terms of being able to analyze the information flow that would be going with the resident. So some of our results, in terms of the use of the form, we were collecting data. We had planned on it to initially be an 8-month period, but we ended up stretching it out to 8 months in order to get enough forms. We were looking to get 100 forms to start with, and we ended up getting 90 out of 247 transitions that we were able to capture from these 11 sites during our 8-month data collection period. That is a much lower number than we expected to find, but it was 36.4% uptake of the form. When you look at the literature on other studies similar to this, looking at the effectiveness of a standardized form, all of their uptakes were between 25 and 35. So we were actually right in the norm. We had just hoped it would be a little bit higher. And the uptake varied dramatically by site and by setting. So in this next graph, you'll see that some sites use the form much more than others. And the sites that had very few forms, 2, 5, 2, etc., they did have more transfers than that, but for a variety of reasons didn't use the form as much as we had hoped. In terms of the forms returning back to the long-term care facility after the resident had received their care in the emergency department, only 2 of the 90 forms were sent back to the long-term care facility. We could only pull out 2. And of the 88 other forms that went to the emergency department, 69 were not returned to the long-term care facility. I'm sorry, I think I misread the first bullet. 2 forms of the 90 were never sent from long-term care to the ED. We found them later on the chart when we did our chart reviews to find out. And so they were completed but not sent. And then of the 88 that were sent, 69 were not returned. So it's still a very large number did not go back to the long-term care facility. And 11 of these 69 were not returned because the patient was deceased in hospital, and that's about a 15% rate, which is a little bit higher but similar to what we found in our original OPTIC study as well. So we found that the completion rates varied very much by setting, which is probably not really surprising because the long-term care facility had the largest burden of work to do in completing the form with 1.5 pages of data elements. So in 57 cases, only the sending LTC completed information on the form. And in 14 of these cases, less than 10 items were complete. So the completion rates were really quite low. In 16 cases, 1 of the 2 pages was missing. And so that's one of the challenges of having a 2-page form that is not connected. And it's one of the points of feedback that we have given is that in future, if you can have a folding 2-page form that's connected in the middle, it would probably be easier, and actually the pages then won't go missing. EMS completed some of the information in 15 forms, and the ED completed some of the information in 5 forms. And there was only in 1 case where all the provider sections of the form were complete. And so this is a schematic that shows, as you can see, the LTC completed the bulk of the information on the form, and we work our way down to 1 form had all of the sections that were completed. But we did have some interesting information in terms of what information was completed and was sent, which I'll go through now. So our results in terms of item completion, we've just added the percent completes to the form, to a copy of the form here on page 2. And one of the things that you'll see is that clothing, glasses, dentures, hearing aids, etc., the percent completion is higher than what we found in our original OPTIC study, where on 687 transfers, this information was available less than 5% of the time across the transfer. Whereas at least with this form, that has more than doubled, because there's an explicit spot to identify whether these items stayed in the facility or went with the resident or were with the family. Many other sections were not completed. One of the things that we've identified as well is that it's important to have a box that says this is not applicable, so that it's clear whether the information is necessary or not. And this is just a summary in terms of the page 1 critical data elements in terms of their completion rates. Reason for transfer was completed pretty much most often along with allergies, 79 and 81% of the time. Principal diagnosis was 69%. Next of kin information is around 50%. Goals of care information was sent 72% of the cases. And this information is, this is about the median of what we saw in OPTIC, where goals of care information was much lower in one province and much higher in another province. The average was closer to 70-some%. And then information about the sending practitioner was identified 69% of the time. As I indicated earlier, the glasses, dentures, personal effects for the resident were noted about twice as often as in the original OPTIC study. And information about the name of the transport staff or the receiving practitioner hospital, that was almost never completed. And then the sending the information back to the nursing home about which practitioner saw the resident, etc., that was also completed only 2 or 3% of the time. So in the surveys that we had asked the healthcare providers, the nurses in the nursing home, the EMS crews, and the nurses and physicians in the emergency department, we asked them to respond to 13 statements about a specific item and how easily they could identify it either on the form or in the record in the pre-data, in the pre-survey. So their responses were on a 5-point Likert scale from never to always. And in the post-survey, because a number of these forms I didn't make it through, or the healthcare providers, many healthcare providers had actually not even seen a form during that 8-month period, we asked them in the post-survey to complete these 13 statements for transfers that did not have a form, as well as transfers that did have a form, and then we were able to compare. So our post-survey response rate was 83%. We had 265 responses out of 318 that we had sent. But of those, relatively few had actually experienced using the impact form. So 68 out of the 265, which is 26%, had actually used one of these transfer forms. So in our survey results, what we did is we used Wilcoxon signed ranked tests to compare the responses from individuals who had used a form and their perceptions of the identifiability of information in transfers without the form. So that was in the post-survey, and I'll run through those numbers. And then we used descriptive statistics to compare the larger cohort of all of the healthcare providers in each of the settings who had not used the form compared with those who had used the form. And overall, we did find, even though the numbers were very small, that, that the use of the form had higher means of identifiable data elements than those transfers without a form. And I'll just go through a few of our results here. So across all of the settings, and this is post-data, post-survey only, so 242 respondents had responded to how easy is it to find the code status for a transfer where this form is not used, and their mean response was 3.44. But of the 68 who had experience using the form, their mean responses were a little bit higher. Again, we did not calculate significances on these because the sample sizes are different, the cohorts are slightly different. But what we do see is that the means are overall higher for those with the form, and these are a few of the factors: baseline mental status, changes to baseline mobility. I found the transfer information needed to care for the resident or patient in less than 2 minutes, because time is important, and accessing information allowed me to provide more personalized care to this patient. All of those means were higher with the form. To break it down by setting, we'll look at EMS first. So again, for the EMS cohorts of those without the form and those with the form, the means were higher, except for lab tests, x-rays completed were easily identifiable. That's where the cohort without the form had slightly higher mean. But then if we drill down into the paired results, this is just one example. For the EMS staff, of the 18 EMS staff who had responded to the statements with the form and the statements without the form, we were able to compare those, and we had complete data on 16 of those. Without the form, the mean was 3.06, and with the form, the mean was 3.56, which is significant. So the reason for transfer was more easily identifiable with the form than without. And it's the same going down for 3 of the next 4 data elements. The baseline mental status was more easily identifiable, and changes to baseline mobility and accessing information that allowed me to provide more personalized care was considerably higher with the form than without. In the ED setting, it was similar. Again, all of these, the means were higher with the form than without the form. And when we look at, again, an example of the paired analysis where we can look for significance, in terms of being able to find the transfer information needed in less than 2 minutes, those who had used the form found that with the form, they were much more easily able to find the information that they needed, and significantly so. And that's similar for all of these that are identified with an asterisk. However, when we go back to the LTC, where we got the survey results from the nurses in long-term care, and we did have a slightly higher return rate here. Here's where the long-term care were much more satisfied without the form than with the form. Now, the 32, 33, and 24 nurses who had identified that they had used the form and also had done transfers without the form, their actual individual comparison, the means were very, very similar. But when you add in all of the rest of the nurses in the cohort who had not used the form, the means of each of these responses were much higher without the form, and therefore the LTC satisfaction with the form was much lower than the other 2 sites. And just from a visual perspective, we tried to put all 3 sites on one screen here, and you'll see that the ED blue line, which is always able to see the reason for transfer, was easily identifiable. The ED was much more satisfied and much more able to find that information than, let's say, the long-term care facilities were. So we did see significant differences across sites. So just to summarize the survey results, when we take all the settings together, the mean scores were certainly higher for using the form than without. But the mean LTC satisfaction was lower for nearly all of those items. And in the paired data, there were significant preferences in the ED and the EMS for using the form, but the preferences were not significant in the long-term care setting. So we also had several open-ended questions on this survey, and we got some very interesting feedback, certainly from the long-term care sites. And you can see from some of these quotes that, that the burden of the work was certainly in the long-term care to initiate the form, to complete the form, and to send it off. And they had no idea whether it was going to be of any use to EMS or ED. So that's part of what our responsibility and what AHS's responsibility is going to be with these results, to show that, yes, indeed, EMS and ED found it useful. But as you can see, that some of the long-term care staff also did not get the feedback from EMS and ED, even in terms of completing the rest of the form. They didn't get the form back, or if they got it back, the EMS and ED portions were empty. So that wasn't very encouraging in terms of being able to, complete the form in the future when it is time-consuming, especially during an emergency situation or while EMS is waiting, etc. So in terms of our summary of the study results overall, just to recap, the uptake and completion of the form was relatively low. 2 of the 11 participating sites ended up not using the form at all. EMS and ED staff scored the transfers with the form as much higher than transfers without the form, and yet they rarely completed their portions of the form in practice. The long-term care staff completed the form more often than EMS and ED, but overall their survey scores were equivocal in terms of whether they thought the form would be useful or not. And the long-term care staff reported finding the burden of the form challenging in light of the time and the effort that it took to complete it. So future efforts to enhance communication around older persons' transitions in care need to take into consideration the balance of the workload required across sites and the benefits that the intervention offers to sites and providers. And there would certainly have to be additional ongoing training and support in the sites to be able to provide this kind of information. There's also some work being done, not necessarily here, but in other sites in North America, to look at an electronic transfer form that could be used, and if that's populated from an existing electronic health record, that would reduce the burden of completion. And then I think it's also important to ensure that any kind of innovation project or initiative like this needs to consider the best evidence in terms of implementation science to actually, talk to the providers in various sites so that they see the meaning of what it is, of the innovation that they're doing, and what the meaning could be throughout the entire process for their patients or for the resident. So at this point, I will stop and we can begin to have some discussion on questions.
Thank you, Greta. Very informative presentation. I do have a few questions for you, as I think we have about 10 or 15 minutes before we have to end. And just to let everyone know, please use the question feature to submit questions that Greta will be able to answer. So I'll start with the first one. In the future, would there be any way to measure the benefit for the resident?
That's a really good question.
So maybe I should have done that at the end.
No, that's okay. That's okay. Well, One of the things that we know from research in transitions is that many of the transitions that seniors have to hospital end up with some negative effects for the resident. So like adverse events, skin wounds, a deterioration in their cognitive status, and a variety of things like that. And some of those rates are up to 25–30% for residents. They come back to the nursing home perhaps with the central issue fixed, but they come with some new issues. And so I think ultimately when a communication process like this is taken up in more than a pilot sense, but is actually done in a full implementation, I think it may be possible to track whether the information is better about the resident and therefore able to mitigate some of these adverse events and side effects of being transferred. It would be a large-scale study, though, to do that.
That's a good answer. I'll go to your second question. Are any of the impact study results surprising? Why or why not?
I think in the end we weren't terribly surprised by the findings. I think we were probably more optimistic as a team than we perhaps should have been, because we had talked about developing this checklist, this form, for a couple of years, and we heard from all the sites that it would be so helpful. So probably the lack of use of the form initially surprised us more, not the actual data element completion rates or the satisfaction even. I think the fact that the long-term care sites couldn't necessarily see the benefit of what they were doing probably changed their satisfaction scores on the survey. But I think there's still an opportunity now to share this back with them so that they can see that, yes, indeed, it is very useful to the ED and to EMS.
Okay. Here's an interesting question. Did you have any means of identifying lost belongings, or were there any occurrences of the form being used to track down these situations?
No, I'm not aware of any either efforts or results in finding lost belongings. Most of our team has talked for the last several years that there's got to be a warehouse somewhere in central Alberta that's housing a lot of dentures and a lot of personal belongings that cannot be found. But that doesn't help solve the problem. Although there is one thing, we have had discussions with the Denturist Society in Alberta for several years, and they've identified that they could put an identifier on each denture, a unique identifier, and have a registry. They just need clearly a little bit of funding to do that, so that if dentures do get lost, they can actually be tracked by a unique identifier. So that's something that's been identified for some time, but there currently isn't a will or a way to implement it.
Geez, that sounds good, especially the cost related to dentures.
Oh, exactly. It's very, very large, and that could be something that could be taken up in many provinces.
Yeah, I agree. I think that this is a problem across Canada and not just to one province. So, okay, so another question. Are you aware of any interventions that improve the flow of information in general from the ER back to the long-term care facility? We have difficulty with basic information such as changes in medications, diagnosis, and procedures performed.
We found in our original OPTIC study that the nursing homes or the long-term care facilities did receive most often verbal discharge, like verbal updates on discharge diagnoses, and that was up to 80% of the time in both provinces. but it was only probably in the single digits, maybe 5% of the time that they actually got it in writing as well as part of the chart. So that still seems to be the main mode of communication, is to have a verbal phone call by the emergency department to somebody at the long-term care facility. We were clearly hoping that this form would be one of those interventions that would help get it in writing, but for this pilot we didn't see that.
Okay. Here's another question. What aspects of the impact study would you modify if implementing a similar communication intervention in your own healthcare system?
I actually wouldn't mind if any of the people online would answer that one.
Let's see if anybody answers that question. I see something just came in. I'll see if that is... I don't see... Oh, can you repeat the question? What aspects of the impact study would you modify if implementing a similar communication intervention in your own healthcare system? Still, I don't see anything.
Okay. Well, then I'll just say one of the things that we would certainly like to see, and we haven't figured out how to do it yet, but is to develop some kind of an app. So there would be an electronic version, of course encrypted and secure and all that, but something that would be more live and maybe user-friendly than another piece of paper. So that's one of the things that we've talked about that could be done as well, and that would align with an electronic health record initiative, of course, which many jurisdictions are working towards.
That's funny you should say that, because that just came up as a non-paper based. So great minds think alike, I think.
Yeah.
So from the same person, Matthew, as healthcare migrates to electronic records, what findings from this work do you think translate from a paper-based form? Maybe it all translates.
I think, yeah, I think a good deal of it does, and I think the data elements that that we think, both our team thinks from the practice as well as the research perspective, that are most important are, the latest clinical elements about the resident, like their blood pressure and their the rest of their vital signs and any other signs and symptoms. That's all really important to have accessible and handy. But it's also important to have information about the residents' preferences. Clearly their goals of care and what they've had done so far, but also things like the fact that they might be deaf in their right ear, and so talk to them in their left ear, left side, etc. Issues around their mobility, issues around them as a person, that perhaps they cannot communicate because so many of them have dementia. And their immediate caregiver may not be with them when they're transferred to an emergency department. So any kind of communication needs to have both aspects, both their clinical data as well as information about them as a person. And that's what we were trying to do in this form, and I think also needs to happen in any electronic version.
Okay. And here's kind of a question to the audience. I'm not sure if they'll have time to answer that, but basically, has anyone in the audience attempted to standardize communication between long-term cares, EMS, and EDs in their healthcare system? So that would be outside of Alberta. And what were some of the challenges? Not sure we'll get an answer to that. So I'll leave that with the audience while I have, I think, one more question. It says, do you think the lack of goals of care completion contributed to death rate in acute care. Example, documentation gap. And there's a clarification. Goals of care that are clear contributed to residents' quality of life and natural death in the frailty, or in the facility, sorry. And that came from Susan.
Yes, we've had both in, perhaps a little bit less so in this study, but a little more so in another study that we're doing called EXACT, which is examining aged care transfers, and where we're examining the decision-making that actually happens in the nursing home when the family and the resident and the healthcare providers are trying to decide, should we send this resident or not at this time. And we have certainly found that while there's a much higher documentation of goals of care, that understanding what those goals of care actually mean in the moment and applying them in the moment are not as clear as what they're intended to be. And so we've done a few other presentations on that as well. And we've been working with Alberta Health Services, their goals of care central group, to try and help bring some more clarity to that. It's better than it used to be, but there's still some aspects that aren't as clear, and everybody doesn't see them the same way. And by everybody, I mean across the different settings, the family, the different healthcare providers, etc.
Okay, I see somebody has, I think, answered the question on the attempt to standardize communication. In my past clinical experience as a paramedic, the results here were not surprising to me. We had a standardized transfer form, but the onus was on the individual paramedic to review it prior to transfer, and incomplete fields were not always considered a priority at time of transfer. Interesting.
Yeah, thank you.
And here's another one. I work for a provincial ambulance service in Nova Scotia, and we had a standardized transfer form in some regions. As a paramedic, I valued the information. However, I think there were problems with completeness and up-to-date information. So it seems that everybody is kind of experiencing the same issues.
Mm-hmm.
Okay. I think that's it. I don't think anybody else has sent in comments on that. So thank you, Greta, for sharing your research and answering our audience difficult questions today. I think they were very good, and it was good to hear some of the audience sharing some of their experience, because I think in most provinces a lot of stuff is the same, but I believe there are differences in the transfer and how much work has been done on improvement. So thank you very much. And just to get some feedback on today's webinar, I'm hoping everybody will complete the brief survey that will pop up on your screen shortly, and will hopefully join us for the upcoming webinars. As you see from the PowerPoint in front of you, Anik Shakir from Laval University will be doing the environmental scan, and James Downer will be doing decision-making and communication tools for hospitalized patients. One on June 1st and the next one on June 15th. And again, just to let everyone know, the webinars and the slides will be posted on our website in the next couple of days. So thank you for attending. Thank you, Greta, for sharing your information, and I hope you can join us on the next webinar on June 1st. That's it.